Faces and also some new faces. We appreciate those of you for whom today was a drive. Like we said, we'll switch locations throughout the curriculum so that at one point or another it won't be such a drive for you in the morning. So welcome to the second module of our Delaware Center for Health Innovation Healthcare Workforce Learning and Relearning curriculum. As you all know, this module focuses on population health management and health IT enablement. And we really appreciate all of you taking the time to be a part of this session today. We have a lot to fit in. It's hard to cover population health in just one day, so we'll move really quickly throughout the day. We've got some wonderful speakers, and as always, we'll be kicking off with healthcare theater this morning. And before we do that, I just wanted to recognize, so our Dean Kathy Matt is here with us today, and she is the lead on this project from the University of Delaware. And Secretary Rita Landgraf, former secretary, is here as well. She's shaking her head not to recognize her, but we're excited to have her now at the university and involved with this project as well. And I'm going to turn it over to Kathy just to say a few words and introduce Healthcare Theater.
So thanks very much. I also want to add to Sarah's welcome. Thank you all so much for being here today. Again, sort of knowing our team on our primary care center and how busy they are every day, I realize that this really is a large commitment for you to be here, and so we are really excited that you are here, and again, I think there's a great program for today. So one of the reasons I wanted to make some comments this morning is Sarah did mention to you, so she said I'm the lead on this particular project and this particular grant. But I have to honestly say it's sort of the lead on a piece of paper. Because I think all of you know that the lead on this project and the person who has really driven it is Sarah Lefebvre. And so I really wanted to recognize her today. She has just done amazing things in our college, this grant and this project and this whole workforce piece, really being one of those pieces in addition to all the things she's doing in the primary care center and Lori's Hands and the many, many projects that she does throughout the state. And I don't know if all of you know, but Sarah actually will be moving on, and we are very sad to be losing her, but she is going on to the next adventure in her life, which is to pursue an MPH at Johns Hopkins. And so I really just wanted, she didn't realize this, but I just really wanted to take this opportunity. So of course I messed up her whole entire schedule and upset her, but I was like, I wanted to take this moment before you get steeped into the content of today to really just have an opportunity to really publicly thank her within this venue for all the tremendous work that she has done. She has and is leaving a lasting impact on us in Delaware, and I'm sure this is not the last we're going to hear of her. So I hope that all of you will join me in a round of applause. So I think somehow, we'll have a little clause there that she has to keep coming back as she's learning all these things, particularly, right, today is focused on population and community health. So we're going to keep tagging back to her, and she's going to keep sending us her ideas. So Sarah, thank you very, very much for everything you do. And so I think, without further ado, I will turn it over to Ellen Carlson and Healthcare Theater.
Well, actually, Joe, hi, thank you. Yes. We're going to turn it over first to my the co-founder of Healthcare Theater, because she's with us today. We don't get this opportunity very often to see her with us because she's all over the place running Simu Care and a lot of other things, but I think she might have a word or two to say about the beginning of this. Please welcome Amy Copperthwaite.
I think that the purpose and the efforts that Alan and I put into Healthcare Theater for the School of Nursing as well as the entire College of Health Sciences has began to bubble up into the community. After our first event, I think it was in February, was the first workforce event, but we've gotten many calls from in the region to go to other places. So tomorrow, Alan and I will actually be traveling to Atlantic City to be presenting to a family practice group there as well. What we're doing today is really trying to bring to light some of the benefits and some of the things that are going to be implemented into the practices and we really hope to kind of bring to life how that can make a difference, not just in the practice that you are working within, but within the patients that you're providing care for. So, go ahead.
Great.
Take it away.
Healthcare Theater was privileged back in the beginning of this year to open up the workforce curriculum grant down in Dover. And we gave you a snapshot look, for those of you who remember, who were there, a look at primary care center. And in one of those little snapshots, we met Florence. And we're really pleased and privileged again today to have Florence back with us. And so we will start our opening scenario right now.
Okay, Grandma. Why don't you rest in your chair, and I'll get you some lunch. You must be starving.
Thank you, sweetie. Ooh. Thank you. You know, the nurse at the hospital said I'd be going home this morning, so I didn't bother to eat breakfast. And then we got talking to the doctor when he finally showed up around noon. So here it is, it's 4 o'clock and I haven't eaten all day. Make something for yourself too. I'm sorry I'm so tired. I should be fixing something for you.
Don't be silly. I'm here to help you. Mom was so mad this morning that she took off of work to help you with your discharge. And she had to go back on trial before you even talked to the doctor. But I told her that we had it covered.
Your mom's much too hard on herself. All she does for me, the cooking and the cleaning and the shopping, it's like she has another child. Now, why does this bottle for my new water pill say I have to be careful taking it when I have diabetes? They knew I had diabetes in the hospital. Otherwise, why were they pricking me all the time? Do you think I shouldn't take it? I don't want to get my sugar out of whack.
No. I think they knew what they were giving you, Grandma. You should take it, right? Well, I could try to get a hold of Dr. Keeler. Or maybe I could try the main line at the hospital. I don't think we have his card or anything.
Now what the heck? This new blood thinner says I shouldn't take it with an antibiotic. But I never finished the antibiotic for my urinary infection before I went to the hospital. And I know you're always supposed to finish the bottle. As my father would have said, damned if you do, damned if you don't.
Okay, here we go. We have chicken in a garlic and lemon sauce, broccoli, and a spinach salad. Now this will have you feeling good in no time.
Oh, thank you, sweetheart. You know, I love the chicken your mom makes for me. Did you notice she put it in small containers so that I can take a little bit out each day? Caitlin, honey, could you get the white bottle off the shelf above the sink for me? Yeah, my head is just pounding. This has been a day for the books.
Slow fade on scene 1. Some time passes. The phone rings.
Hello?
Hi, Mrs. Lawson. This is Carl, calling from Dr. James's office. I've been thinking about you all day. I'm so glad to hear that you're back home. How are you doing?
Oh, Carl, I'm so glad you called. I should have thought to call you. Things have been so wild around here, I don't even know which end is up. How did you even know I was in the hospital?
We signed up for a service offered in the state of Delaware to be notified whenever one of our patients goes into the hospital or the emergency room. I got the notification last night, and I talked to Dr. Keeler a little while ago. It sounds like he prescribed some new medications for your heart.
And you didn't say that again.
Oh, well, I know that was probably a whirlwind in the hospital, so I was hoping that we could walk through a few really important things. I know they talked to you about testing your blood levels now that you're taking the Coumadin. Did they explain that some of the other things you need to be careful of when you're taking that medication?
Oh, I don't know. I was so lightheaded in the hospital. You know, I just could not eat that much they gave me, and you know what that does to my blood sugar.
That's okay, Mrs. Lawson. We'll talk through everything together. Is your daughter there?
No, Cindy had to go back to the courthouse. You know, I felt so bad for her, sitting all morning in the hospital with nothing to do. But Caitlin's here.
Oh, great, your granddaughter. What would you think about putting the phone on speaker? Do you have a speakerphone?
No, I don't have one of those phones.
No problem. We can talk through some of the things together. Maybe Caitlin can help jot down some notes for you. And then I want to get an appointment scheduled for you to come in sometime tomorrow to see us. Dr. James wants to be sure she's on the same page with everything Dr. Keeler prescribed. And I want to show you how to test your blood. It's a little different from checking your sugars.
Wow, I feel like 100 pounds has been lifted. Caitlin, could you get the rest of my pills from that shelf in the kitchen? Let's get this straightened out. Carl, do you do this for all your patients? You must never sleep.
Well, I try to call all of our patients who are admitted to the hospital to make sure that even if things change while they're admitted, they're still our patients, and we want to be with them every step of the way in their care. But remember how we talked a few months ago that with some of the different issues you've had with your heart and lungs and your diabetes, that we included you in our special high-risk panel of patients? We try to identify people who may need extra support based on what we know about their diagnoses, their healthcare spending, and other factors. So you are our special VIP, and therefore we keep special tabs on you.
Well, I'm glad somebody does. Sometimes I don't think the right hand knows what the left hand is doing. Now let me tell you what this one label says.
Slow fade to the end and the end of the scene. I have our actors stand up and take a bow.
Alan, you're going to walk around with the portable mic because we're going to ask the audience to kind of give some feedback.
More than happy to do that.
Great. So just wanted to kind of take a minute and let you guys think through and process some of what you just saw. And what were some of the highlights, some of the things that stuck out to you that Florence was really having a hard time with at home before she got the phone call?
Oh, sorry. Medication reconciliation and also her diet, like she's on blood thinners, so she shouldn't be getting spinach and things like that. So and broccoli,
Yeah, so you definitely saw some warning signs, some things that were going in there. She was confused about what medication she was supposed to be taking. Should she be taking the Coumadin and the antibiotic? Should she continue to take the antibiotic? And then there was another medication. So anything else that was of concern?
She left the hospital without having a meal, and as she got home, she was late in getting another meal. So the missed meals with her diagnosis of diabetes is concerning.
Yeah, so, and that can happen at discharge, right? We all think it's going to be 7 a.m. in the morning, and then it gets pushed to be 4 o'clock before the ambulance shows up, or before the doctor comes in, or before an x-ray is read, or something along those lines, and before you know it, they haven't had much to eat. Anything else that...
She wasn't clear on her discharge instructions, so many times when people are discharged from the hospital and the nurse goes in and does the teaching, the patient is not prepared or receptive. So she was unclear on her discharge instructions.
And I actually was talking to Florence, who in real life was discharged, and when she got home to check her discharge instructions in the folder, there was an empty folder. So that can even happen sometimes where, you know, they're picking up the wrong folder for discharge or something along those lines. Anything else?
With our question, they went over and she said, well, if they gave it to you, you should be taking it. Sometimes it's not determined that medication is right for you or not.
Right.
So making the assumption that if it was given to you, you should take it because they should know what they're doing.
Right. So, you know, again, thinking about people that are not in the healthcare world and not really understanding, they figure if it was prescribed or if it was given, and not really questioning that, not going back to a higher authority. What do you think the difference was with that nurse calling in? Oh, sorry.
No.
Yes.
Just no follow-up contact information.
I'm sorry.
No follow-up contact information.
Contact information. So the granddaughter didn't know who to call, right? There was about 3 or 4 different options thrown out: the main hospital number, her doctor, and I can't remember the third one. But thinking about who is that point of contact. What do you think the difference was with that the nurse calling in and kind of getting started on a conversation?
I felt like when the nurse called, he gave her a way out. She seemed very overwhelmed from the beginning to the end. And when the nurse called and gave her like a solution, like, okay, we're gonna work on this together, we're gonna get it figured out. He kind of set her mind at ease a little bit to, he gave her that comfort of knowing that it's gonna be okay. You can calm down, it's gonna be okay.
And so from that piece, is there anything else that you really saw as something that stood out from that phone call that made a difference for that potentially future readmission that probably was coming down the pike?
The follow-up appointment being really quick after discharge.
So, yeah, so bringing her in pretty quickly after discharge. Anything else?
The medication, going over the meds to make sure she had when she was discharged. Very important.
Yeah, so going, again, clarifying things, making sure that maybe we weren't completely overwhelming her on that phone call, but that we were saying, okay, let's get, you know, we'll get through this together, and there are some things that we've got to talk through.
The blood sugar is the difference between a Coumadin and check blood sugar and a regular blood sugar.
Mm-hmm.
And one of the docs that are at the table with me, we noticed that you identified her as a high-risk patient. You also called her a VIP, which actually we wrote down and we're going to steal, because we classify them as high risk, and they may not know what that means, and that term may actually scare them. So telling them they're a VIP as opposed to, you know, we risk stratified you when you're in this high risk category, I think it's a really good thing. So we're going to implement that.
Yeah, I think again, that's really what we're trying to point out is we don't necessarily have to use the term high risk with them. We know what it is, right? But the VIP or the MVP or something along those lines really makes them feel as though they're special and important, and it makes them feel as though they can almost call in at any point in time, and that, you know, we're waiting for them, kind of, you know, the concierge service, right? Right. Great. Anything else?
He asked if there was support in the family, so to kind of help guide her daughter, and knowing that the granddaughter was at least there, so at least there would be someone there to help her, assist her through the whole process. So it's that partnership piece.
And even permission to get on, you know, would it be okay to put speakerphone on rather than just put the speakerphone on? Yeah, exactly. Anything else?
What stuck out for me was how we all know primary care is such a relationship-driven field, and the fact that she knew Carl by name, and he said, "Oh, Katie's there," like he knew that she had a granddaughter, you know, and that's somebody that patient can trust. So I think that's important, that when we have people calling our VIPs, it's not just any person, but it's somebody that the patient knows and trusts.
So that point of contact, which was we were saying was missing from that discharge, who do we contact if we have questions? I agree with you. And I have to say personally, I'm an ER nurse, that's my background, so that relationship building hasn't always been there from my perspective, but when I was getting my master's degree and I worked within a family practice physician's office, I really witnessed that firsthand, how much development that relationship developing happens and how that impacts the care. You know, it's just so powerful. And understanding that support system and what potential pitfalls you might find along the way. So definitely appreciated that. Anybody else have anything from that information?
I'm currently a care coordinator, so what they just use your skit is basically what I do calling patients post-discharge. And it makes a huge difference in preventing utilization to an inpatient or steering away from an ER. So that trusting relationship that's built is huge, because sometimes they'll call me asking if I can call the doctor if they're not able to get through, if I can make an appointment for that day, or have them come in to be seen by my nurse practitioner to steer away from going to the ER for something so simple that we could, do a little education over the phone and do the red light, green light, yellow light, so they know their symptoms on when to go to primary, when to actually go to the ER, when we're like, no, you really do need to go to the ER instead of being an extra LASIK and stuff like that. So building the relationship, is a tremendous amount of help for preventing admissions.
Great, great. Does anybody else have any comments or thoughts about the impact of that phone call? What were some of the things that the nurse utilized that was implemented that really helped her or him know that they needed to make a phone call, that they needed to be impactful? So what were some of those resources that were used?
The notification system.
The notification system? What else? So that high-risk panel piece was kind of the second thing, so.
Have a high-risk registry so they know who their high-risk patients are.
Right.
High-risk registry so they know who their high-risk patients are.
Right, kind of that
It can be
dashboard.
a report that they get that know that the patient was in the hospital when they
Right.
came out.
Right, exactly. And so really today was about focusing on the expectation and the responsibilities that it takes for all of us to care for our patients. And even when they aren't sitting right in front of you, there are things that we can be doing that really can alleviate those readmissions and confusion and frustration on behalf of patients as well as their caregivers and loved ones. And today, we're really going to be talking about some of those things, and this is just kind of a way to open up those doors and maybe just start talking about population health and how we can make it better. So Sarah, I think I'll be turning it over to you.
To Jacqueline, actually. Yeah, thank you so much.
Great. Thank you.